Welcome to the Emergency Preparedness and Response Orientation at the North Bay Regional Health Centre. Emergency situations do occur in hospitals. The timing of these emergencies is not predictable. The fact that they will occur is predictable. A systemic approach is required when responding to emergencies in order to reduce risk and to ensure the necessary response is activated and the resources needed to manage the situation are deployed. Learning objectives are to explain patient and community expectations of the North Bay Regional Health Centre, list and define the emergency response codes, explain the purpose of and how to use the flip charts, and review training responsibilities. What is expected at the North Bay Regional Health Centre? Patient expectations. Patients expect that they will receive safe, quality, patient-partnered care. When receiving care, patients are looking for staff members who are knowledgeable in emergency situations and are familiar with the appropriate response for that situation, and that the response will occur in a timely and effective manner. Community expectations. The larger community of North Bay expects the hospital to take a leadership role in the emergency response. The hospital is a participating partner in the city's Emergency Management Committee, and participates in mock disaster events in order to assess and test the response plans that have been developed. Scope and priorities. The foundation of good emergency response is that responders must be safe to be able to perform assigned duties. Priorities when responding are personal safety. Can I safely respond to the situation? Others. Can I safely assist other hospital community members? Reporting. Issues to expedite response and minimize potential impact. Render assistance. Find people to help to make the response more effective. Know code procedures. Knowing how to respond when required to do so. Hospitals in Ontario utilize their own terminology and systems for emergency situations. The Ontario Hospital Association standardized the terminology for identifying codes in hospitals by establishing a code color system. 13 codes were identified. The purpose of this was to ensure that information was conveyed quickly, it would alert staff, and activate the response plan for which every situation was occurring and would not create panic. For example, announcing fire over the PA could create panic and anxiety versus announcing code red. In most areas of Ontario, 911 is the universal number for getting emergency assistance. At the hospital, 5555 is the same as 911. The 5555 number is a dedicated code line at switchboard. The number can be called from any phone in the hospital. The number connects you directly to switchboard to guide you through the call and get the assistance you need to your location. When calling 5555, be specific to the type of emergency you're facing. This ensures the correct responders are notified. And be specific to your location so responders can find you and get the assistance to the area in a timely and effective manner. There are well over 100 flip charts throughout the hospital. The flip chart provides a quick reference outlining actions to be taken to manage a code situation and the response expected from staff. The flip chart is another tool in your emergency response toolkit. All codes will be paged overhead. Then switchboard announces, for example, attention, code red, pod A2, level 200. This will be repeated 2 times. The response to the code will depend on which code has been activated. Code red means fire. When coming upon a fire, staff should remember the acronym REACT. R, remove occupants. E, enclose area. A, activate the nearest fire alarm pull key station. This is the most important step of this procedure. This will bring an immediate response from the fire brigade and the North Bay Fire Department. C, call code overhead. Call 911. Give your name, location, and extent of the fire. T, try to put out the fire with the appropriate extinguisher, only if it is safe to do so. Unit-specific maps are available. They outline emergency exits, routes, pull key stations, fire extinguishers, and fire hose cabinets. The REMAR tool is used to reflect that a room has been searched and is vacant. Responders will not enter those rooms. Never flip the REMAR to white unless you are sure the room has been searched and is vacant. Key stations are located in all mental health areas and complex continuing care. A key to activate the station is provided to all staff working in the West End by the managers. How to activate a key station. The key station is used for first stage only. Alarms and strobe lights on ceilings and walls will be activated at the onset. Second stage activation is only used in a code green, which stands for evacuation, as this will unlock all the magnetically locked doors, including secure areas. The hospital fire warden, North Bay Fire Chief, the hospital CEO, or delegate are the only ones who can activate a second stage alarm. The fire brigade, made up of environmental services, Johnson Controls, and material management staff, has two functions. 1. Bring extinguishers and water containment unit to the scene. And 2. Function as the evacuation transport team and assist with moving patients out of the affected area to safety. Stored combustibles should be kept at least 1 meter away from sprinkler heads. Stairwells and exits should not be used for storage of combustibles. The entire building is an enhanced fire protection device. Avoid bumping sprinkler heads with things like brooms and ladders. You could activate the sprinkler. With these systems, water runs at 30 gallons per minute. Code green means evacuation. This will be a total or partial evacuation, usually following an event like a fire, bomb threat, active threat, and so on. There are 3 evacuation movements: vertical, 1 floor down to another; horizontal, across a single floor on the same level; total, entire facility. 2 stages. Stage 1 alert means that staff are preparing for a possible evacuation. Stage 2 means evacuation is necessary and staff will be directed to commence moving patients and personnel out of the identified area. Evacuation is managed through the Incident Command Post, or Emergency Operations Center, by the Incident Commander, or Emergency Executive Control Group, utilizing the Incident Management System. Flip chart maps include all points of exit. There are designated areas to bring staff patients throughout our community. Sweep work areas, including washrooms and storage areas, to ensure all rooms are evacuated. Activate the REMAR accordingly. Remember, sweeping of an area should only be done if safe to do so. In a code green, the sweeping and activation of REMARs should occur on the way out. MedSled is the device we use to transport people who cannot get downstairs on their own. Training for proper use of this device will occur in your department. There are 2 types of sleds, standard and bariatric. Bariatric is used for individuals weighing more than 300 pounds and for those who have a lot of medical device needs, for example, a patient from the intensive care unit. The following video demonstrates the use of the MedSled.
Your place of work has made a great decision to implement the MedSled in its emergency evacuation plans. Now that you have it, let's take a short moment to demonstrate how easy it is to use. While evacuating, always use 2 people while operating the MedSled. The sled is designed to evacuate non-ambulatory individuals in your facility. This means that if a person cannot safely walk down a flight of stairs, they should be evacuated in a sled. First, reach into the MedSled carrying case and pull out the sled. Undo the Velcro strap around the sled and unroll the MedSled. Once the sled has been unrolled, pinch in the sides and the sled will easily keep its shape. Next, we are going to load the evacuee into the sled. Wrap the evacuee in his or her sheets if they are in a bed. Roll him or her onto their side and place the sled next to the evacuee. Slide the evacuee onto the MedSled. Make sure they are positioned in the center of the sled with their hands at their sides and their feet resting at the foot of the MedSled. Fasten the 3 cross straps for security. If the evacuee requires any extra padding, place it in the sled at this time. To move the evacuee from the bed onto the floor, rotate the sled while on the mattress and use the rigidity of the sled to safely lower the evacuee down. Do not lift the evacuee off of the mattress and place him on the floor. Let the sled do the work for you. Drag the evacuee toward the stairwell using the orange foot strap at the bottom of the sled. While dragging the evacuee, one or both of the evacuators can pull the sled. Notice how the sled has cocooned around the evacuee to protect them from doorways, equipment, and other people or obstacles in the hallway. The med sled makes transporting evacuees down stairwells an easy process with its revolutionary stairwell braking system. Position the evacuee to the outside of the stairwell along the wall. At the top of every sled, you will find the stairwell brake secured with a thick Velcro strap. Undo the Velcro strap and hook the carabiner to the top railing bracket attaching the stair rail to the wall. Never attach the carabiner to the railing, as this could allow the carabiner to slide along the rail. Always attach the carabiner to a wall bracket or a solid anchor point. To begin the descent, one evacuator should operate the braking tether, while the other evacuator should guide the sled down the flight of stairs. Always make sure that you keep the braking tether tight and never stand directly in front of the sled. Slowly pull the sled over the edge of the top step. Keep the braking tether as tight as possible to prevent any jerking as the sled begins its descent. Once you have the sled on the stairs, slowly feed the tether through the carabiner and lower the sled down the steps. Never begin the descent unless the stairwell brake operator is ready. Station one employee on the top landing and one employee on the bottom landing of each flight of stairs. For large-scale evacuations, this will form a bucket brigade in the stairwell. Each employee will send and receive evacuees in the bucket brigade. Once you receive an evacuee onto your landing, slide the sled over to the next flight of stairs.
There are two stages of Code Gray. Stage 1, external air exclusion. This means the air outside the facility is contaminated. Heating, ventilation, air conditioning should be shut off. Movement in and out of the building is limited to 2 locations that are run by protective services. There are 2 enclosed airlocks, one at the main entrance east and one at the main entrance west. Code Gray Stage 2, infrastructure failure. This means the loss of essential services, including water, hydro, natural gas, medical gases, communication, and information systems. These outages can be caused by accidents, severe weather, and so on. Code Brown is a chemical spill. There are 3 stages of response. Stage 1 is localized. The department will clean up its own mess. Code Brown cleanup kits are located in work areas. Stage 2 is called overhead and will be responded to by the Code Brown response team, who will lead the cleanup. Stage 3, an external company, is called. You must retrieve the proper material safety data sheets and bring them to the scene. There are 7 steps to take when a chemical spill is discovered. Stand back, protect yourself and others. Assess the hazards using the material safety data sheet. Call for help 5555 if required. Plan a response, contain the spill, clean up, and dispose the waste. We live in a city with rail lines, highways, industrial complexes, an airport, and a military base. External disasters in any of these areas could activate a Code Orange response. There are 2 types of Code Orange. A spike event activates a response to a disaster where a large influx of patients demands additional resources for a short period of time, such as a multiple vehicle car accident. A surge event, which activates a response to a disaster where a large influx of patients demands additional resources over an extended period of time, such as the collapse of a building like a mall. Stage 1, alert, influx may occur. Stage 2, active, influx is imminent. Stage 3, deactivated. CBRNE stands for Chemical, Biological, Radiological, Nuclear, Explosive. It is a subset of Code Orange. It refers to the uncontrolled release of chemicals, biological agents, or radioactive contamination into the environment, or explosions that cause widespread damage. These events can be caused by accidents or by acts of terror. The response team is led by protective services and supported by the appropriate experts. Code Blue means cardiac respiratory arrest. If a person is in cardiac or respiratory arrest, call 5555 and initiate CPR if you are trained. The critical care unit nurse, the emergency department physician and nurse, and the respiratory therapist respond to all Code Blue calls at the North Bay Regional Health Centre. Once the Blue team arrives, it assumes Code leadership. Crash carts are strategically placed throughout the hospital. Flip chart maps indicate crash cart locations and identify staff to respond. Code Pink is a cardiac arrest involving an infant or child. With a Code Pink, staff responds the same as with a Code Blue, with the addition of a pediatric and a neonatal intensive care unit nurse. A Code White is activated when a disruptive behavior is escalating and you feel your safety or the safety of others is being compromised. No one is exempt when it comes to responding to a Code White. It could involve patients, staff, doctors, and even visitors. There are a number of different ways to activate a Code White. Dial 5555 within the hospital, use Spider Alert, use the panic stations in the parking lots, and some staff use Vocera. For patients, Code Whites are led by clinical staff. All other Code Whites are led by protective services. All available and trained staff respond to Code White. District Acute Hospital staff will respond to all Code White pages east of and including the cafeteria. Regional Mental Health Centre staff will respond to all Code White pages west of the cafeteria. Protective Services personnel will respond to all Code White events. If resources are not sufficient to manage the situation, a second page will be called, whereby all available and trained staff will respond to the location regardless of where it is. Code Purple means there is a hostage situation in the hospital. The safety and welfare of hostages and the hospital community is a top priority. During a Code Purple, remember the ICEN principle: isolate, contain, evacuate, negotiate. Immediately call 5555 and provide as much detail as possible. Protective Services will take the lead and will secure the area until police arrive. Upon arrival, police assume full control until the incident is resolved. Code Silver means there is an active threat in the hospital. Again, remember the ICEN principle: isolate, contain, evacuate, negotiate. During a Code Silver, there are 4 responses. Get out. If possible, get out of the area and find a place to hide. Do not return until directed to do so by Protective Services or police. Hide out. Find a safe place to hide in the area. Turn off lights. Secure the door either by locking or barricading the entrance. Turn off volume on electronic devices. Call out. Once you feel you have found a safe place, call 911 for help. Take out. If no other choice exists, attempt to take out the threat. Code Yellow means a patient is missing. There are 2 stages of response to a Code Yellow. Stage 1 is an unannounced localized search of the unit. The area search captain will coordinate the search. Protective Services will be called at 8800 and may initiate a lockdown if the patient is under the age of 18. Stage 2 occurs if the patient is not located. Call 5555 and initiate Code Yellow. An incident command post is activated, and the incident commander coordinates the search. If the missing patient is under the age of 18, a Code Amber is called. Code Black is a bomb threat or a terrorist activity. The safety and welfare of staff, patients, and the hospital community is a top priority. If you receive an email or a text, do not delete it. Notify Protective Services immediately at 8800. If you receive a phone call, don't put the person on hold. Prolong the conversation, note as much as possible, follow the flip chart Code Black checklist, and search the area as directed by the incident commander using search maps. If you discover a suspicious package, do not touch. Call 5555. The hospital's emergency response training and resources include the Emergency Response Committee, emergency response policies and procedures, flip charts, maps, departmental training, and regularly scheduled mock code exercises. Remember, the 911 of the hospital is 5555. The Personal Health Information Protection Act is referred to as PHIPAA. This legislation requires you, by law, to protect the privacy of our patients' personal health information. Failure to do so or inappropriate access to a patient's personal health information are privacy breaches and lead to very real consequences, up to and including termination. This presentation will review your role and responsibilities with respect to complying with the rules of PHIPAA. Personal health information is any identifying information about a patient or former patient and includes verbal discussion about the patient as well as anything in writing, whether in paper or electronic form, photographs, videos, and audio recordings. Personal health information is defined as information relating to both physical and mental health, information about the care provided and the identity of the care providers, information about a plan of service under the Long-Term Care Act, information about donation of a body part or other bodily substances, information about payment or eligibility for health care services when it refers to a specific patient, information about health card numbers, the name and contact information of a patient's substitute decision maker, and any type of record or recording that contains the above information. PHIPAA was put in place to give all healthcare providers in Ontario a consistent set of rules around the collection, use, and disclosure of our patients' personal health information. The need for clearly established rules about patient privacy was based on the increase in electronic health records, enabling easier and faster access and exchanges of information. Patients' increasing ability to access any number of different health providers in multiple settings. Recognition of the fact that data shared amongst their various healthcare providers was important to patients and safe patient care. The fact that sharing of health information via electronic databases requires built-in privacy and security requirements. As a staff member, physician, volunteer, student, or hired contractor of a hospital, you are involved either directly or indirectly in patient care and have access to personal health information in some way, shape, or form. Therefore, you are responsible for complying with the PHIPAA by keeping all personal information you have access to private and secure. The North Bay Regional Health Centre also has privacy policies that you are expected to adhere to, and you may be subject to specific professional standards around patient privacy. PHIPAA makes it very clear that we are allowed to collect only information that we require for us to provide care to do our jobs. PHIPAA has explicit rules about disclosure or sharing of information, the types of patient consents that are required, and the circumstances under which consent is not required. PHIPAA addresses the rights of patients to access their own information. PHIPAA tells us that we must have processes and safeguards in place to make sure that our records are secure and available only to authorized individuals. Processes include having privacy policies, requiring passwords, and locking up paper records. If you are providing care to a patient or need the information to fulfill your role, then you are in that patient's circle of care. The circle of care can also include external healthcare providers who are actively involved with the patient's care, for example, the family physician or the Community Care Access Centre. Remember, when you're not on duty or not on call, you are not providing care, so you are outside of the circle. When you are in a patient's circle of care, you are entitled to access information on a need-to-know basis. That is, the information you need to perform your role safely and accurately. You are permitted to share information with others who are also within the circle of care on a need-to-know basis. The circle of care is patient-specific and will change if the patient is transferred to another unit within the hospital or discharged. PHIPAA outlines specific rules around the consent to collect, use, and disclose personal health information. There are rules around implied consent and express consent, as well as the circumstances where information can be disclosed without seeking a patient's consent. Implied consent means that you are permitted to assume that the patient consents to the sharing of information amongst those within the circle of care. For example, when a patient is transferred to another facility, you can provide personal health information to the receiving facility, unless the patient tells you not to. If we are treating a patient and request records from another healthcare provider who tells us that they will not provide any information without consent, we will obtain the patient's written consent. Express consent is required when information is being disclosed to third parties who are outside of the circle of care. Express consent means that the patient says, yes, you can disclose information about me to my family, my friends, my insurance company, my lawyer, the police, or anyone else who may require it. It is generally preferred that express consent is captured in writing on a consent form. PHIPAA specifies when disclosure of personal health information is permitted without obtaining patient consent. This includes when required to do so by law, to prevent a risk of harm to the patient or to others, and to identify and/or contact the next of kin of a deceased individual. You are responsible to keep personal health information private and confidential, to ensure that records are secure, meaning protected from loss or inappropriate access, to not disclose or share patient information without that patient's express consent unless you are doing so within the circle of care. Remember that there is no right to access any patient's information simply by virtue of your status at the North Bay Regional Health Centre. You must be involved in that patient's direct care or require the information as part of your role. You must follow the policies and procedures developed by the North Bay Regional Health Centre for the use and disclosure of personal health information for secondary purposes. If you become aware of a breach or potential breach, you must inform your manager, the Chief Privacy Officer, or the Coordinator of Freedom of Information. Patients have a right to access their own health records or request correction to their record, but there is a process to be followed. Please refer the patient to or contact the Clinical Records Department. Please note that you also have to contact the Clinical Records Department to access your own information. Accessing your own electronic health record is contrary to hospital policy. If a patient tells you that they do not want their information shared with other healthcare providers or they have a complaint, please refer them to the Coordinator, Freedom of Information and Privacy. Patients may also complain to the Information Privacy Commissioner's Office of Ontario. The North Bay Regional Health Centre has taken steps to ensure that PHIPAA is followed. This includes establishing policies and procedures, taking security steps with respect to electronic information, including requiring passwords, assigning electronic access only as required, and conducting audits on who accessed personal health information. It includes providing privacy education and having a process so that patients can ask that their stay in hospital is not disclosed to any callers or visitors. This is addressed in the North Bay Regional Health Centre Request for Anonymity policy. A privacy breach is any loss of or inappropriate access or disclosure of personal health information, whether intentional or accidental. The North Bay Regional Health Centre takes patient privacy seriously, and there are real consequences to privacy breaches. One example of a privacy breach is accessing the information of a patient that you are not providing care or service to. More examples of breaches include seeing a coworker's name on a patient list and then looking up that coworker's personal health information in Meditech, or telling other coworkers about the admission. Looking up the personal health information of your family members, including information about your child. Discussing patient information in the cafeteria, coffee shop, designated smoking area, or on social media. Or telling your family or your neighbor that someone you know is in the hospital. The North Bay Regional Health Centre investigates all reports of privacy breaches or suspected privacy breaches, and if the breach is proven, action is taken and may result in discipline, up to and including termination of employment. A privacy breach includes intentional and unintentional actions, such as deliberately seeking out someone's personal health information for the sake of curiosity, or accidentally, such as faxing a document to the wrong number. Privacy awareness is crucial. Don't make assumptions that you can discuss a patient with a coworker who has no involvement with that patient, or that you can access information of family, friends, or coworkers if they ask you to do so on their behalf. These would be privacy breaches. Please know that what you do on a day-to-day basis to be sensitive to and respectful of our patients' privacy is greatly appreciated. Infection Prevention and Control is a program in place to help contain known infections from coming into the facility and to prevent transmissions and infections to others. We identify transient concerns within the facility as well as in the community. Ongoing education takes place through orientation, e-learn, the blog, and other venues. We work closely with the Public Health Unit and report communicable diseases. Practicing good infection control helps decrease patient and staff exposure to disease. It also helps decrease the financial burden on the hospital as well as the patient, and decreases the hospital length of stay. Whether you are a frontline worker giving direct patient care, or a support staff member, or even a volunteer or visitor, everyone is responsible to prevent the spread of infection. In order for transmission of infection to occur, microorganisms must enter the body through the mouth, eyes, or nose, or a break in the skin. Taking good care of your hands and your skin is very important. By performing good first assessment and isolation guidelines, and implementing personal protective equipment, and performing hand hygiene, we can help halt the chain of infection. Performing good hand hygiene, either through soap and running water or alcohol-based hand sanitizer, is the number one way to help prevent the spread of infection. It is important that hand hygiene be performed the right way as well as at the right time. The 4 moments of hand hygiene include: clean your hands before initial contact with the patient or patient's environment, before any aseptic procedure, after any body fluid exposure risk, and after patient or patient environment contact.
To help stop the transmission of microorganisms moving from one place to another and from one person to another, the Center for Disease Control and Prevention has recommended a set of procedures and techniques reinforced by OSHA, specifically designed for the healthcare industry. Whether your job involves direct patient care or indirect patient care, we've learned that proper hand hygiene is the single most effective way to help prevent the spread of infection. Your hands are the most likely place for you to acquire and spread microorganisms brought into your facility every day by patients, visitors, or even fellow employees. Since we can't always know who's carrying infectious pathogens, all patients entering your facility must be treated as potentially infectious. And although jobs may vary, it's everyone's responsibility to do the best they can in maintaining consistent infection control practice. But unfortunately, this isn't always the case. What's wrong with this picture? Or with this picture? Or this picture? Or with this picture? Or this picture? Or with this picture? What's wrong with this? If we could do it all again, adhering to your facility's bloodborne pathogen policy and exposure control plan, the outcome would follow the integrity and consistency of a safe and responsible infection control program. Remember, the purpose of this plan is to eliminate possible sources of infection and avoid spreading infection. Get the picture? All linen should be treated as infectious, inside or outside the patient's room. Proper hand hygiene is everyone's responsibility because it's the single most important defense to help prevent the spread of infection. During a busy workday, schedules can often be hectic. Being in a hurry, tired or upset, or just not feeling well can seriously affect your performance.
Hey, Darren.
Hey, JR.
How's vacation?
Oh, it was great.
I sure could use one.
And the outcome could be a major disaster. Hand washing will help stop the transmission of potentially infectious pathogens from both recognized and unrecognized sources. Take a few seconds after a procedure to clean your hands. That extra moment of care will ensure a safe working environment. To help understand the importance of hand hygiene, let's discuss how your hands may play host to these microorganisms and see how they are spread. The surface skin on your hands naturally carry many microscopic organisms. Some of these, called resident flora, are present all the time. There are also bacteria which you pick up during the course of a workday, called transient flora. Most transient and resident flora are found in the top layers of the skin, although 10 to 20% can reside in deeper epidermal layers. Hand washing is the most effective way to combat and remove these microorganisms which may cause infection. All microorganisms can easily survive in moist areas, as well as on or near jewelry. It's recommended, with the exception of wedding bands, to leave all jewelry at home. Jewelry, long or artificial nails can interfere with effective infection control technique. To be effective, you must wash your hands properly. When washing your hands, first wet your hands using warm water. Use soap liberally and make lots of lather. Wash the front and the back of your hands vigorously for 10 to 15 seconds, paying close attention under and around fingernails and between fingers. Then, rinse well under free running water. As you let the water drip off your fingertips, reach for a clean towel to dry your hands. Get another paper towel to turn off the faucet so you don't recontaminate your hands. For standard infection control precautions, this simple hand washing procedure will reduce the spread of dangerous microorganisms. Washing your hands correctly is only half the picture. The other half is the type of soap you use. It's best to follow your hospital's particular policies on which type of soap to use. Medicated or antimicrobial soaps are recommended for high-risk areas and procedures, including working in surgical areas, post-op, critical care units, newborn or neonatal intensive care, labor and delivery areas, and with immunocompromised patients. You can wash your hands with non-medicated soap after providing routine patient care, such as taking a patient's blood pressure, weighing patients, administering medication, or other non-invasive procedures. Additionally, those in non-direct patient care areas, such as housekeeping, food service, administration, maintenance, and laundry, can also wash with non-medicated soap. If your hands are not grossly contaminated, alcohol-based hand gels can be used between hand washing. Using bottles of alcohol-based cleansing lotions, foams, or gels makes hand washing very quick and so very easy. That's good infection control. Knowing how to wash your hands is important. Just as important as knowing when to wash your hands. Let's take a closer look. You must wash your hands after going to the bathroom. Clean your hands after handling patient waste or specimens. Clean your hands after any situation in which you have come in contact with blood, mucous membranes, or other body fluids, including secretions or excretions, moist body substances, as well as any other potentially infectious materials. Always clean your hands before and after touching any wounds. Wash your hands whenever finishing lab work. Even if you wore gloves, wash your hands. Gloves do not take the place of hand washing. As a reminder to wash your hands, think about where your hands have been in a single day. Wash your hands before and after handling food, especially raw meats, which are a reservoir for potentially infectious bacteria. You should wash your hands before eating meals too. Remember to wash your hands both before and after providing any type of hands-on care. Even if you wear protection, some infections can reach the skin. Wash skin surfaces to remove the bacteria which could be transmitted to others. It's a good infection control practice to wash your hands before you begin work and before you leave work. In an emergency situation, which may involve police, paramedics, ambulance crews, firefighters, or mobile blood personnel, alcohol-based rinses, foams, impregnated swipes, or other antiseptic hand cleaners are an acceptable and convenient alternative to hand washing. Wash your hands before and after contact with patients, regardless of whether or not gloves are worn. Remember the importance of hand washing immediately after removing gloves or other protective equipment. What's inside a room we take out, and what's outside a room we take in. And after any contact with blood or other infectious materials. Wash your hands before invasive procedures, or before providing care to any severely ill or immunocompromised patient or newborn infant. After any personal hygiene matters, including using the toilet or even touching and blowing your nose. And before eating. Remember to take adequate time to wash your hands thoroughly and correctly. Hand hygiene is the best defense against the spread of infectious microorganisms. It's an important component of personal hygiene, and more importantly, you'll be helping to protect the health of others. The continuing concern of drug-resistant organisms and serious viruses and other diseases make infection control as important as ever. Get the picture?
In a hospital boardroom, somewhere in America. The case of Whitney Ross. What went wrong? In a way, I think we all wish that the result of her case had been related to her appendicitis. But it wasn't. So what went wrong? And what can we do to fix it? Whitney was a sophomore in college, an excellent student with dreams and goals. She came to be in post-op after having an appendectomy.
Still doing a little bit of everything.
Yeah, yeah.
But this IV line still really hurts.
Well, like I said, I can try moving it to the other arm.
Yeah, whatever you could do.
Sure. Is that a rash?
Oh, my cat scratched me a few days ago. I told them when they took my history.
Okay. It shouldn't be a problem if the IV is down by the wrist.
Thanks. Sorry to be such a bother.
I'll be back in just a minute.
Okay.
The probable source of the infection was down the hall. Tom wasn't even supposed to still be there, but he contracted a MRSA infection at his surgical site. His daughter, Kelly, unfortunately didn't understand that even though she was just a visitor, she was also a part of the healthcare team.
Hey, my dad could use an extra pillow for his back.
Okay, I'll bring you one in just a second.
Kelly had been educated by a nurse about the barrier precautions and the dangers of healthcare-associated infections, but she didn't quite grasp how just one lapse can cause infection to spread. Dina? She was a good nurse, but was burned out with stresses at work and home.
I know you're always busy with all the paperwork you're doing, but if you could get to us soon.
She wasn't going the extra mile to ensure the safety of patients.
I just need another minute or two, and then I will bring you a pillow, yes.
Okay, thanks.
She recognized Kelly wasn't using the gloves correctly, but didn't use the opportunity to educate, and didn't take personal responsibility for cleaning a potentially contaminated surface.
Whitney's IV still hurts. I'm going to try moving it to the other arm. Can you cover Mr. Daniels for a few minutes?
Yeah, I wasn't going to finish this anyway. Thanks.
Nathan? He was the director of the post-op unit. He'd come back from a conference on patient safety and infection control, motivated to make a difference. But he never instituted a sustained effort. Real change never happened. So an otherwise responsible new nurse just out of school never got the message. She was using gloves so she didn't also feel the need to wash her hands. Nathan's staff did everything right when he was around. But there was no sense of ownership, no real change. There wasn't 100% commitment.
Oh, that's so much better. Thank you.
Let me know if there's anything else you need, okay?
Straight A's this semester and $1 million.
Okay, set your sights a little lower. Just buzz.
The infection preventionist working with post-op was Janice. Janice couldn't successfully implement a team approach to infection prevention.
Hey, can I talk to you for a minute?
Why? What's wrong?
She was always considered an outsider.
Nothing's wrong. I just wanted to follow up with you on some ideas.
She lacked the skills to successfully coach staff members, and so everyone's awareness of healthcare-associated infections suffered as a result.
Is it cold in here?
I don't think so, but I can get you another blanket. Good.
The nurse made a note in a chart, but didn't alert anyone until after shift change.
Temperature is 101, blood pressure 145/97, nothing moving in her GI tract, hypoactive bowel sounds. Looks like it's ileus.
Guess you stand another day.
Yeah.
Let's see what Dr. Kennedy says.
Thanks. Manuel, in his third year of med school, he longed to make a difference.
A temp of 101 is fairly typical for appendicitis. Let's monitor the postoperative ileus for 24 hours.
But the patient got worse.
She's been acting a little confused, but her temperature went back down. What concerns me is her arm. Look.
Manuel had been watching the case all day. He suspected the patient's condition was getting much worse.
I saw that. But it's here in her history. Her cat scratched her arm and she got a rash. Did you read her history, Manuel? Let's stick with
Dr.
the...
Kennedy directed the team to continue the antibiotics already prescribed for her appendectomy and closely monitor her condition.
Monitor for peritonitis. I'm on call this weekend. Alert me if she doesn't respond.
But Manuel's rotation in post-op was almost over and he didn't want to stick his neck out. Manuel accepted the attending's course of action without objection. When it came time to make a difference, he didn't speak up, even though the problem was staring him in the face. 48 hours later, the nursing assistant took Whitney's vitals at shift change, including a temperature of 97 and blood pressure of 90/60. But Manuel just recorded it and never related to the nurse or bothered Dr. Kennedy because it was the weekend. It was a chain of events that should not have happened. By the time she reached the ICU, she was suffering from organ failure as a result of sepsis. And then...
Hey, Dr. Green. Everyone. The ICU just called me. Whitney from 204, she had a MRSA infection in her bloodstream. She passed away. I'll be around to talk with everyone, but...
Any one of several individuals could have made a better decision, and Whitney might be alive today. She came in with appendicitis. But everyone knew that a patient had just died from poor infection prevention and poor communication.
What's wrong?
What could they say? They said what had too often been said.
Nothing. How can I help you?
No, my dad is asking about...
What happened? Whitney joined countless others who have died of an infection acquired during their care.
The Office of the Patient Advocate is located and operates within the North Bay Regional Health Centre. It maintains an independent mandate for investigation, providing confidential advocacy services to all patients and families of the hospital. In Ontario, patient complaints and resolution processes are a requirement of all hospitals, subject to the Excellent Care for All Act legislation created in 2010. In addition to the advocacy mandate, the Office of the Patient Advocate is also responsible for the management of the North Bay Regional Health Centre Compliments and Complaints Policy. An overall requirement of the Excellent Care for All Act is that all hospitals in Ontario must have a patient bill of rights and responsibilities, and that it be connected to the complaints resolution process. In simple terms, it is what one can expect from a hospital when one is a patient, and that you can raise an issue should you need to. For example, respect, dignity, communication, and choice. Our Patient Bill of Rights and Responsibilities identifies the patient's values and what is important to them. It was taken with community and stakeholder input, and any future revisions must do the same. You can find these both on our intranet and internet sites under Patient Rights. The vast majority of advocate issues and complaints that come forward to the office have a connection or tie to these rights and responsibilities. The Advocate Office is responsible for categorizing and maintaining complaint data in accordance with the Advocate Provincial Standards and the Excellent Care for All Act. All information remains confidential and is only shared with client or family consent or when the law supersedes. That is, when someone is imminently at risk of harm to self or others. Here are the three main categories with some examples within each. Legal examples include forensic clients' involvement regarding the Ontario Review Board hearings and orders, legal aid applications, capacity to consent to treatment or manage finances, consent and capacity board application and legal status under the Mental Health Act, and police investigations and interviews. Therapeutic examples include the patient or family is not in agreement with the diagnosis, medication is offered and refused, or a feeling of being coerced into a medication plan, a change of doctor, being put into seclusion or dealing with adverse events, and surgical errors. Social examples include access to meaningful activities, PIN money access, activities on and off hospital grounds.